Good morning, this is Mrs. Page, and today we're going to be talking about acute inflammatory bowel disorders. So as a review, digestion of the food and absorption of nutrients is going to occur primarily in the small intestine. Water is reabsorbed in the large intestine to help maintain fluid balance and promote the passage of waste products. First, we'll talk about peritonitis, which is inflammation of the peritoneum. It is caused when bacteria leaks into the peritoneal cavity through a perforated ulcer, ruptured appendix, perforated diverticula, necrotic bowel, gallbladder rupture, abdominal trauma such as stabbing, or peritoneal dialysis. Signs and symptoms that you will see most common is going to be the rigid board-like abdomen. They can have acute onset of diffuse severe abdominal pain. Movement can intensify this pain. Tenderness is noted to the entire abdomen with rebound tenderness. You might have some guarding. Diminished or absent bowel sounds because peritoneal inflammation will inhibit peristalsis. Progressive abdominal distension from the fluid shifting into the peritoneal cavity. Nausea and vomiting, fever, malaise, tachycardia, tachypnea, restlessness or confusion, and oliguria. Assessment, you want to check their signs and symptoms, see what signs and symptoms they're having, assess their pain, ask if they have a history of GI disorders like peptic ulcer disease or gallbladder issues, ask about their current medications, get some vital signs, complete a focused abdominal assessment, and check their level of consciousness. Complications of peritonitis, it can lead to septic shock or hypovolemic shock from the fluid shifting to the peritoneal cavity. Bacteremia or septicemia, which is bacterial invasion of the blood from bacteria responsible for that peritonitis. And then respiratory problems from the increased abdominal pressure against the diaphragm from the intestinal distension and fluid shifts. Diagnostic test, you will have a CBC with white blood cells elevated, might get some blood cultures, BUN, creatinine, and a hemoglobin and hematocrit to determine the fluid status. Abdominal x-rays will determine if free air is present under the diaphragm as a result of perforation, and serum electrolytes. You can see an abdominal x-ray right here. This is actually the diaphragm that's being pushed up because of all this air. Usually a diaphragm is going to be down here in this area. So you can see all of this free air that's pushing the diaphragm up, which is pushing up against the lungs, which is going to cause those respiratory problems because they can't get a big deep breath. Treatment-wise, they'll get IV antibiotics and surgery. There is a laparotomy with a peritoneal lavage. So they will have open abdominal surgery, and then they will rinse out that peritoneal cavity, close it back up. They're going to have a Jackson-Pratt drain or a Penrose drain, and it might be left unsutured because of any inflammation that can occur during the healing stage. There will also be NG tube to prevent distension of the stomach and intestines, and then there'll probably be TPN until adequate oral intake can resume. Interventions for peritonitis, you want to monitor pain and assess the effectiveness of pain medications. Unrelieved pain or a change in the location, severity, or type of pain can indicate the spread of infection, abscess formation, or other complications. Place the patient in Fowler's or semi-Fowler's position with the knees and feet elevated. This will reduce stress on the abdominal sutures, it facilitates respirations, and it promotes comfort. Non-pharmacological pain relief measures such as massage and guided imagery. Maintain accurate I's and O's. You should report if the urine output is less than 30 mLs per hour, which can indicate decreased cardiac output and renal dysfunction. Weigh the patient daily, measure the drainage output, monitor IV fluids, provide frequent oral hygiene because they will be MPO, monitor for signs of infection, ensure meticulous hand washing and standard precautions are being used to prevent further infection, sterile techniques for dressing changes, and maintain nutrition because malnutrition impairs the immune response and slows healing. Next, we'll talk about appendicitis. This is inflammation of the appendix, and it's the most common reason for emergency abdominal surgery. Signs and symptoms, you will see pain that starts as generalized pain in the upper abdominal area, and then it will descend and localize in the right lower quadrant. Pain will intensify, and it's aggravated by walking, moving, and coughing. You will find rebound tenderness at McBurney's point, which is midway between the umbilicus and the anterior iliac crest, and this is McBurney's point in this picture. You can see that it's right over top of this appendix. Sorry, guys. You'll see a low-grade fever, elevated white blood cells, anorexia, nausea, vomiting, and flexion of the knees to the abdomen, so the patient will be in like a fetal type position because they're in pain. Assessment, you want to check their current signs and symptoms. Ask them about recent food or fluid intake because they will more than likely have to go to surgery. Ask them about medications, get their vital signs, complete an abdominal assessment, and assess their pain levels. Complications of appendicitis can include perforation, which can lead to peritonitis and sepsis. Diagnostic test, you will see a CBC with a moderate increase in white blood cells and an abdominal ultrasound. Medical treatment, you want to keep them NPO to prepare for the possibility of surgery and avoid making this inflammation worse. They should receive IV fluids for volume restoration and the prevention of electrolyte imbalances. They will receive IV antibiotics, pain medications, and, if needed, surgery, an appendectomy, so surgical removal of the appendix. Let's talk more about an appendectomy. There is laparoscopic and open. So laparoscopic is going to be the preferred method, but they might use an open laparotomy if the appendix has ruptured. Preoperatively, you want to keep the patient NPO if appendicitis is suspected because they can go for surgery. You do not administer laxatives or enemas because this can cause perforation of the appendix from that increased pressure. You can apply ice packs to the abdomen for 20 to 30 minutes. You do not want to apply heat because heat increases circulation to the appendix and that can cause perforation. You want to monitor for signs of perforation or peritonitis. Monitor for changes in pain. So a sudden relief of pain can sometimes signal that the appendix has ruptured. Position the patient in a semi-Fowler's position so drainage is contained in the lower abdomen. Monitor bowel sounds and administer pain medication and assess the effectiveness of this pain medication. You only want to administer pain medication after a diagnosis is confirmed and surgery is scheduled, specifically opioid analgesics, because if you administer opioids, it can mask the signs and symptoms of, if we go back to a sudden relief of pain, that can signal that the appendix has ruptured. So if we give someone opioids, we might miss that sudden relief of pain because it's masked by those opioids that we just gave. Postoperatively, you want to assess the incision for signs of infection. Advance the diet gradually as tolerated when bowel sounds return. Assess the effectiveness of pain medication. If the appendix is ruptured, there might be an NG tube and a Jackson-Pratt drain, so monitor drainage of these. And teach the patient to avoid lifting, stretching, or strenuous activity until their follow-up appointment. Lastly, we'll talk about gastroenteritis, which is inflammation of the stomach and small intestines. There are different types of causes of gastroenteritis. There's viral and bacterial and parasitic. So viral, such as norovirus, rotavirus, astrovirus, or adenovirus. The astrovirus is fecal-oral route, and the adenovirus is fecal-oral route and possibly respiratory droplets. There are bacterial causes of gastroenteritis, such as Campylobacter, from undercooked poultry, unpasteurized milk, or diarrhea from dogs or cats. There is C. diff, which is common in hospitalized patients receiving antibiotics, E. coli, salmonella that can be transmitted by consuming undercooked eggs and by contact with reptiles, birds, or amphibians, Shigella and Staphylococci, and there can also be parasitic causes of gastroenteritis, which can be transmitted from person to person or contaminated food or water. And Giardia and Cryptosporidium are 2 types. Signs and symptoms of gastroenteritis. Usually they are self-limiting and last about 3 days. You'll see diarrhea, borborygmi, abdominal pain and cramping, malaise and weakness, anorexia, nausea and vomiting, and signs of dehydration. Assessment, you want to ask about recent travel, if they've eaten at any restaurants in the past 24 to 48 hours, if they've gotten any food from the farmer's market, or if they have eaten any kind of raw fish. And then you want to complete an abdominal assessment. Complications of gastroenteritis can include electrolyte imbalances and acid-base imbalances. Diagnostic tests for gastroenteritis, you want to include stool specimens and electrolyte levels. Treatment will be antibiotics, possibly antidiarrheal meds, but these medicines can prevent the infecting organism from being eliminated from the body, so these are used relatively rarely. And they might have oral or IV fluid rehydration. Interventions are going to include hand washing and sanitizing surfaces, teaching proper food handling and maintaining appropriate temperature of the food, teaching adequate cooking of meat products, reinforcing not to consume raw meat, encourage patients to avoid milk that has not been pasteurized, and encourage travelers to only drink bottled water. So that is all I have for acute inflammatory disorders. If you guys have any questions, please feel free to reach out to me.